Madam Nadira Chaturvedi for the role of the Patient Advisory Council and how do you monitor that? For those of you uh, who do not know Nadira ma'am, she's going to be very famous very soon. Madam Nadira Chaturvedi is the co-chairperson of the Patients for Patient Safety Foundation. She's extremely dedicated to the cause, and we are very delighted and happy to have her as the co-chairperson of this great initiative, Patients for Patient Safety Foundation. Over to you, Madam.
Thank you, Dr. Lallu. That was a wonderful presentation. Gracie ma'am, Dr. Ashok, all of your presentations, I think built the stage for me, and I'm delighted to know, and I'm thanking everybody here in advance for getting this concept, this dream, this idea that we just came up with a few months ago as a wish list. And somewhere in the cosmos, somebody picked it up, and Dr. Vijay and Dr. Lallu have converted that into a structured webinar now. So it's always good to dream. But from the concept, then we came to the construction. How do you do that? What do you construct? And I think both Dr. Ashok and Dr. Lallu have explicitly explained why, how, because the perspectives of the patients, the perspectives of the same person towards the same nurse or different people are different. And that creates confusion, mistrust. And I think the ownership part, somebody mentioned decision-making. When you take ownership for your actions, the dissonance goes and you become part of the plus or the minus, the fallout. So I think the two crucial parts why we began this patient safety initiative to involve patients is basically, yes, ultimate goal is to reduce medical errors, but the doctors do that better. But with the participation, with the awareness of the patients themselves, we could perhaps achieve a better result. And that is why the structure has been created so far. But planning is something, I mean, you plan your work, but you work your plan. So I think my next presentation is about how you work that plan. The planning has been done so far. Next slide, please. So the roles, understanding the roles, Rabina, are you handling that? Yeah, thanks. So as there are three components to the structure, the patient representatives, the healthcare representatives, and what stitches them together will be the facilitator. So understanding your own role, understanding the work that you have to do is the first part in any job description and orientation. How you do it, when you do it will be the second part, and whether you did it will be the third part. So coming to the first part, the patient representative, or PR as we are calling it, must, as Dr. Lallu mentioned, must be committed both in terms of energy, time, skills, and stay within the mandate, the scope as somebody called it, the domain as somebody else called it, but we cannot interfere with things that we are not supposed to interfere. However, the patient's perspective will gradually come into the picture. So the very first thing the PR has to understand is there is a certain area in which they can play around with the playing field, and you have to give time without which nothing happens. The next three are basically engaging and communication. I would simplify this into a three-dimensional responsibility. Number one, the PR brings forward collective perspectives. As I mentioned, there are diverse reactions, but a collective perspective, not your own, it's not your personal agenda, and presents it to the PSC. Now, within the PSC, they also present it to the healthcare people, which means they're doing a double role, bringing an outside collective and giving it to the HCP. And the reverse, the third dimension, therefore, is whatever happens, whatever actions, whatever is done, it is equally important to report back to the patient community so that there is transparency and a continuous cycle of improvement. So engaging with the community is basically that, facilitating is within the PSC, and dealing with the HCP is the next part. Yes, next slide, please. So the three-dimensional communication role. Now, the hospital representatives have a little more, not just three-dimensional. They, of course, again, the first two are common. You have to understand that what we are doing is not to blame anybody, not to nitpick, not to fight, not to do anything negative, but it is to increase the patient-centered care. That is our single point agenda, if I may commit that. And therefore, time, attention, effort And a genuine open-minded commitment would be the most important. Now, the third part is an important one, which nobody else can do. Translation of medical terms into clinical terms for a patient is difficult. I may just say, I had a bad needle. Somebody didn't give me a good injection. It could be the cannula, it could be the needle, it could be the vein, whatever. That's for you to make us understand. So therefore, the translation of the medical language into layman's language would be one of your important points. Just as patient representative brings the collective wisdom or the collective voice of the patients, so also the HR brings the collective voice of the hospital community, and the issues that are also faced by doctors towards patients. Without this, the partnership would be incomplete. This is a partnership. It is nothing more, nothing less between patients and hospital and care providers or medical practitioners. So therefore, this partnership will be important and fruitful only if each one hears the other side. By the same token, whatever is decided, the added responsibility, therefore, is supporting implementation of the initiatives. Once a decision is taken collectively, it will be the HR's job to implement them within his or her organization. And nothing is complete unless you talk about it or report back to the community. Two communities here, patient community as well as the hospital. So therefore, the role is not just communication and translation, but actually giving place and giving a space to each other's voice. Next slide. Next slide, please. Now, who stitches this together? If the HR is busy with the clinical work, the OPD, the IPD, there has to be somebody who does the work on the behind. Calling for meetings, as Lallu ma'am said, the meetings must be done. The minutes of meetings have to be done. There is resources to be allocated. There is communication, there's facilities, the support has to be given. So basically organizing, I won't say leading, the chairperson would lead it, but ensuring that everybody attends, tracking it, and feedback again, that implementation has been done, and recommendations have been done, and just a reporting forum. So that is the facilitator's job. I think the very name is important. But the commitment of the facilitator will make this program very, very effective or very, very done. So let's not underestimate their role. Next slide. Next slide, yeah. Now that we have decided who's going to do what, because that's the next part of management, we need to know whether we really decided and we really did it. Nothing that cannot be measured can be improved. Or in other words, if you can measure something, you can improve something. That's the adage we have in management. So what needs to be measured? Again, it's open, it's voluntary, it's for you to decide, it's for the committee to decide. Perhaps these things will also change from time to time. What is the definition of success? To a small hospital, to a big hospital? Is it sentinel events? Is it stockouts of medicines? Is it too much expired medicines, which dents your financial balance sheet? So it will be, there is no single line here, there is no single answer, but it will emerge from collective and consensus. It may be a specific change, maybe in the reception, maybe in the outpatient, maybe in the billing. So these measures must be identified, quantified, and targeted. That's what we mean by KPIs. And they will be reviewed in terms of the actual performance. Next slide. So therefore, the evaluation, when we talk about evaluation, it is basically comparing what you did with what you were supposed to do. Who did it? When was it done? That's what it has to be done. So I would even begin right from the minutes, right from the meeting. Did we have enough meetings? If we said 6 in a year, did we have 6? Did we have 5? Did we have 7? If we said everybody had to attend twice, did we attend? Did we not attend? If we circulated the minutes, were the actions taken? Were the responses collated? Were they presented back? Feedback will be another important role. Feedback again from 3 people, the people who do it, which means the hospital staff, the people who report, that means the patients, and the people again from the feedback within the members itself. So the feedback again can be a tricolor kind of a feedback. Collectively, therefore, this will help to say that yes, we are doing it, and we know we are doing it, and we are ensuring that we're doing it. So evaluation is nothing but ensuring that what you do, what you have to do. This is all internal. Next slide. Maybe when we grow a little bigger, smarter, and are more confident, we can even invite outsiders to evaluate. Outsiders could be very professional, large corporations or the big four, or it could be just another department, or it could be another large hospital or another brand, or an agency like Kaho or NABH, anybody like that. So evaluation doesn't mean only a PwC or a BCG, but an external view is always better than just an internal view. That's the point that's making it here. Next slide, please. So therefore, once you've done it, you know what you're supposed to do, each one does it, each one gives the feedback that it's done, and you communicate back to the people, to the target segment, namely the people, the patients who are now your customers, who are now your main stakeholders, and also pat the backs of the hospital staff who actually did the work, who actually took the trouble, walked that extra mile beyond their normal duties to find solutions and make it more patient-centric. I think both need a pat, and therefore recognizing and celebration is part of life and part of our ongoing process. Let's not forget the patients, let's not forget the staff, and let's not forget the PSC. Only then the PSC can sustain. Thank you.
Thank you so much. Thank you so much, ma'am, for bringing out the essence of monitoring, measuring, evaluating, and above all, celebrating success. And that's extremely crucial. That smile, that celebration, a coffee and a tea will make a lot of difference. And once again,